Yes, please.
Good afternoon, sir. At the very onset, I'd like to thank Dr. Kumar and his team to giving me an opportunity to speak in front of you. My topic is echocardiographic assessment of shock. Now, echo is a very powerful tool. It's almost called a front door echocardiography operates in time critical situation. That is, it works day and night. It's cheap, easily available, and gets focused data. Now, what are the common environmental situations where we are asked to do an echo in an ICU? When the shock is not improving despite the initial therapy, that is, the diagnosis is in doubt, or what is the complication in a known MI patient, or whether there is a diagnosis of admitted with a diagnosis of acute pulmonary embolism, and the clinician is in doubt that whether it could be an acute cor pulmonale, and in a tamponade, how much is the fluid, which way to drain, what is the unexplained mechanism of hypotension after a surgery or even a pacing, whether it's a cardiogenic pulmonary edema or it's an ARDS. So there are multiple situations where we want to know from the echocardiographer what is the status of the patient. Now, shock is a not so uncommon situation. Almost every alternate patient in a ICU or a critical care unit is admitted with a shock. It's a life-threatening generalized situation where there is a tissue hypoxia, and the causes may be in the pump where the heart is failing, or there is acute pulmonary embolism, or in the pipe where there is sepsis, or in the tank where the patient has bled a lot or has acute gastroenteritis or a dengue septic shock or that sort of situation. So, shock can be a multifold etiology, and the aim of the echo is to focus on 5 F's. What is the fluid status? What is the function of the heart? How much heart is filling? What is the flow? That is the situation of the valve. Or what is the form? So we must get a focused data that will help the clinician to chart his path. Now, in a cardiogenic shock, what are the main things we look after? One is the systolic function status, what is the stroke volume, what is the valve status, what is the diastolic status. And before we start our study, the minimum basic things you should be the comprehensive history, the clinical state the patient is admitted with, what is the height, weight and age, the ECG, if it's available, the BP status with or without inotropes, what is the rhythm, what is the provisional diagnosis. Now, the first and the most basic question the cardiologist or an intensivist will ask, what is the EF? Now, EF is a red herring, and it's a very subjective matter. Now, two things, for an experienced operator, eyeball estimation gives a more or less good idea what's the EF. Another very subjective and objective parameter that has been validated is the EPSS. Now, if you give a EPSS, say it's 10 or 11, automatically the clinician will know there is something wrong with the ventricular function. Now, this EPSS parameter is less reliable if there is an arrhythmia, AF, or in a valve pathology, or in a mitral prosthesis. Now, common cardiac situations where what we face are systolic heart failure, the diastolic failure, the pulmonary embolism, or the tamponade. Now, this is the basic picture with which we started with. What is the eyeball estimation of EF. If you are an experienced operator, the clinician will value your eye estimation of EF, and it has been seen that it gives more or less a good idea of the LV function status. Next thing, we want to know what is the, if it's a cardiac shock, what is the coronary artery that is involved. So in the back of your mind, when you are with your right hand or left hand is with the probe, you must know what coronary artery you are dealing with. See, this echo shows LV hypertrophy, dilated LA with a central or mildly eccentric MR, and the LV EF, there is a mild systolic dysfunction. Now, another most important thing is, see, the interatrial septum is bulging toward the right atrium. So you know, as soon as you put the fourth chamber or the parasternal long axis view, you know the LA pressure is high and the patient is in failure. It could be both diastolic failure with elevated LA pressure. Now, another thing, when you comment or when you write down the report, you must know, right, what you are writing. Number one, whether you is normal wall motion. Second, which you like to call it hypokinetic, with scar or without scar, or a partial thickness scar. And to an experienced echocardiographer, he will categorically tell you it is hypokinetic, there is no scar, or there is a scar and that is partial thickness. So it's non-QMI or subendocardial infarct or a transmural infarct. The clinician will know, yes, it's correlating with my diagnosis. Now, what is the dynamic objective parameter with which you can help the cardiologist? You can measure the stroke volume. Obviously, to measure the stroke volume, and you have to know the VTI. Now, one major problem in the ICU is, sorry, I'm running short of time. You must know how much you have to get a good apical 5-chamber view. Next, you must know the diastolic function, the status, the LA pressure. Now, the rule of thumb, you add 4 millimeter of mercury to E by A ratio. Now, this is not very sensitive, but it's a workable formula. Now, another thing, you look after the IS motion. There is a grading, and it's not so old grading, where you can indirectly assess the degree of LA pressure by movement of the interatrial septum. Now, there are certain special populations where the rule of diastolic grading do not apply. One, if there is atrial fibrillation, if there is pulmonary hypertension, or if there is constriction, or a severe mitral annulus calcification, while lateral annulus velocity is less than the septal velocity. So there are special situations. So remember, when you are reporting the LA pressure, remember these situations. Now, in atrial fibrillation, I think Dr. Dey has dealt enough how to assess the atrial LA pressure in atrial fibrillation. And I was listening to the diastology lecture in the morning. There is recently published guideline by British Society of Echocardiography. They have used LA strain to categorize the intermediate group, whether it's reduced diastolic compliance or normal diastolic compliance. So it's recently published in the June. You can go through that part. Now, next point is you look after the valve. Now, nowadays, non-surgical intervention is advanced so much in a high volume center. Almost any valve can be dealt with in a percutaneously through artery to help the patient. Now it's the hypovolemic shock. Now, if you are dealing with a hypovolemic shock, you must see the size of the ventricle. In a small ventricle, almost collapse, we call it kissing ventricles. With it's a very important critical situation, because surviving sepsis guideline always says that any shock, whether it's a cardiogenic, non-cardiogenic, or undifferentiated shock, you give or infuse 30 milliliter per kg crystallite, and that saves the patient. Now, next point is IVC. How to predict right atrial pressure? there is a rule, if the IVC is dilated and little collapsing, the LA pressure is high, and if it is not dilated but collapsing, it is intermediate. If it is less than normal size and collapsing more than 50%, then the LA pressure is 5 or less. Now, one thing we must remember, if the patient is on ventilator, the situation is totally different, because in a ventilator works in a reverse Valsalva physiology. During inspiration, normally the IVC collapses when you inspire. In the ventilation, when the intrathoracic pressure increases, either the IVC dilates or it doesn't collapse. So the collapsing of the IVC must be interpreted with caution in a ventilated patient. Now, how do you assess the volume status? You look at the patient. If it is not on ventilator, spontaneously breathing patient with more than 25% collapsing IVC, you can give a fluid challenge. And in a ventilated patient, if it is collapsing more than 18%, then only you can give a passive fluid challenge. Now, another method is the dynamic method. You can calculate the LVVTI variation. If the LVVTI is varying with beats and it's more than 20%, then you have if it's a shock patient, you can always give a fluid challenge of 30 milliliter per kg to resuscitate the patient. But remember, if it is having an arrhythmia, a very high heart rate, you cannot give a fluid, and you have predicted a high LA pressure. In that case, the next option is you can raise the leg, and the raising of the leg will transfuse the patient with 300 to 500 milliliter fluid. So that is a very good alternative method to see whether fluid challenge can raise the BP and resuscitate the patient. And you look at the obstructive shock. These are very telltale signs. I am not going to RV function, pulmonary hypertension we had yesterday. One thing I would like to mention categorically, in a dehydrated patient, if the patient is having mild concentric hypertrophy, it may cause LV outflow tract obstruction, and that is not hypertrophic obstructive cardiomyopathy. Remember,
Dr. Biswas, please wind up the session, please.
Yes. So, distributive shock is commonly seen in sepsis, and there can be dilatation, there can be hypertrophy, there can be hypertrophic obstruction, and there can be diastolic dysfunction. So, there are many protocols, you can find it. So, in a ICU critical care patient, echocardiography is almost a invincible instrument to help the intensivist or a cardiologist. Thank you.